Thank you. So to this audience, I think talking about nitric oxide is bringing coals to Newcastle or beer to Leuven, where I'm from. Just to remind you, nitric oxide is a very important regulator in normal cardiovascular homeostasis. It's produced by two enzymes, the endothelial and the neuron isoforms, and it produces limited amounts of the gas molecule. In disease states, however, it is induced by an inducible isoform, NOS2, and it puts out a lot more nitric oxide molecules, which contribute to disease, as we will discuss further on. As a framework to think about how I would structure the short presentation, in normal biology, this is the signaling cascade, and there's this very important central second messenger, cyclic GMP. So many of the early effects of nitric oxide in normal signaling are thought to be mediated through its downstream effector, cyclic GMP, through the guanide cyclase stimulation. And then it targets the heart, the blood vessels, the kidney, other organs, the brain, and it has all sorts of beneficial effects. It is a very highly expressed enzyme that generates this low-level nitric oxide, as you can see here in stainings that we did from a coronary artery, from a young person, and all the endothelial cells really light up and express a lot of this enzyme, as do small microvascular endothelial cells in the heart, like 5 of these surrounding every cardiac myocytes and generating this important molecule. So it has all these beneficial effects in normal function. In disease, however, there is deregulation on many different levels. There is impaired generation in the endothelium. There is then impaired generation of cyclic GMP or enhanced degradation by phosphodiesterases that all contribute to important disease entities such as ischemic damage to heart, to brain, to kidneys, and the heart failure syndrome, which we will further focus on, be it with reduced or preserved ejection fraction. And I will review, just for all of these 3 entities, just a key number of observations that we and many others have performed over the years. During ischemia and reperfusion, be it during PCI, what we do every day in the cath lab, or surgeons during cardiopulmonary bypass, there is reperfusion of a temporarily ischemic substrate, and that reperfusion by itself induces additional injury. Now, that is thought to be mediated by several mechanisms, including oxidant-free radical generation, the endothelial dysfunction, but also activation of circulating blood cells, such as platelets, white cells that are activated, and ultimately the hit on the cardiac myocyte is eventually leading to mitochondrial dysfunction, loss of the mitochondrial membrane potential, and apoptotic cell death of the cardiac myocyte. As you know, cardiac cells have a lot of mitochondria shown here under normal conditions. These are all EM pictures of mitochondria, and you see during ischemia and reperfusion, this is from an animal model that we have, how these mitochondria are disturbed during the reperfusion phase. In heart failure with reduced ejection fraction, the major hit is at the level of the cardiac myocytes. You lose cardiac myocytes in ischemic injury, and there is subsequent upregulation of downstream effectors such as phosphodiesterases. We know this because, we looked at patients with end-stage heart failure, be it a dilated phenotype or an ischemic phenotype, and what you see here compared to control is very highly expressed phosphodiesterase expression in the cardiac myocytes in brown here, and the concomitant fibrotic remodeling. This is the Western blot. The question, of course, is this an associative phenomenon, or is it causally related to the heart failure phenotype? And that's why we developed a mouse model where this is some years ago, of course, where we overexpressed PDE5 under the control of the myosin heavy chain promoter, and then submitted these mice to all sorts of different stresses, including myocardial infarction. And to sum up our findings, you can see here, this is the sham PV loop after a wild-type infarction, so there is deterioration of LV function, of course, volume expansion, and you can see here the dramatic further adverse remodeling when you overexpress PDE5. So it would be a logical target in therapies for heart failure, as we will come back to in a minute. The other flip of the coin is the heart failure phenotype with preserved ejection fraction. It was nicely alluded by Johannes in his talk. And there the major hit is at the microvascular endothelial layer. You can think of HFpEF as a systemic inflammatory disease where there is and driven by comorbidities, because all these patients suffer from a lot of comorbidities. And so the major hit is a generalized inflammation of the microvascular endothelium. And this is a very nice paper, and many of you have already alluded to it at this meeting, by Joe Hill, where in the double hit mouse model, he identified increased expression of iNOS, and this increased iNOS expression with a lot of oxidative stress generates this reduced expression of an Xbox protein, an unfolded response protein that contributes to the HFpEF phenotype. So again, indication that too much NO, nitrosative stress, leads to the heart failure phenotype with preserved ejection fraction. So then you might ask, how can we address this? Are there good ways of addressing this heart failure burden using pharmacological interventions at the different levels that I alluded to that are critical in mediating the phenotype? I will show a few of those and where we are today. And then is there, and this is what we and many others are working on, are there novel approaches that you could envision to meet the unmet clinical need in this phenotype? So 3 examples, or a few examples here on the pharmacological approaches that have been pursued over the years, both at the level of NO donor compounds, chemical molecules that release nitric oxide under the right conditions, trying to stimulate the natriuretic peptide signaling system, whereby through binding with particulate guanidate cyclase, you also increase cyclic GMP signaling, or blocking the degradation of cyclic GMP by PDE inhibitors, or directly stimulating the soluble guanidate cyclase isoform. So at all these levels, clinical trials have been pursued, all trying to boost cyclic GMP signaling and hence protect the heart, kidneys, and blood vessels. Just a few examples. First, the Paradigm HF trial looked at patients with impaired systolic function, HFrEF phenotype, and showed that there was a 20% reduction if you treat them with a new molecule, sacubitril, which impedes the degradation of these natriuretic peptides, endogenous natriuretic peptides. And so what was observed is that there was a 20% additional reduction in heart failure hospitalization and cardiovascular mortality. Another recent study, Vericiguat, is a guanidate cyclase stimulator that looked at a sicker patient population with a reduced ejection fraction and observed a modest, just significant reduction in the same endpoint in these sicker patients. But when I look at these data, you don't only see that the glass is half full, but also half empty, because it means that there is still, despite optimal medical treatment, at 2 years, an event rate of 20% in the trial patient in this highly publicized trial. But in those trials that included older patients and sicker patients, you can see that the event rate, even with the best of therapies that we have today, is 40%. So definitely need for improved therapies. And that's, I think, why we're all here. Another example, in the equally large cohort of heart failure with preserved ejection fraction, there's been many trials over the years, and this is one of the nicer ones by Maggie Redfield, trying to increase the signaling in these patients and cyclic G signaling by isosorbide mononitrate, these pharmacological NO donor compounds. But what they observed in this phenotype is that this was a dose increasing study, 30, 60, and 120 milligram. And if you look at the physical output or the quality of life and the VO2 and exercise capacity of these patients, it was an impairment that was dose dependent. So these patients did not do well on this therapy. And you may already guess why when I showed you the Joe Hill model. Increased nitrosative stress if NO donor compounds would also increase radical formation. Under these conditions of several comorbidities, patients don't do well. At the same time, when you try to block the degradation of cyclic GMP by phosphodiesterase inhibitors, 2 major trials also neutral effects, no benefit in patients with preserved ejection fraction. So definitely we need to develop better therapies there, and nitric oxide donors or PD inhibitors are not the right answer. Could it be of value in ischemia reperfusion injury and protect the heart? That was a study performed in the UK, where at the time of myocardial infarction, these patients received, right before the opening of the blocked artery, an IV infusion of nitrite, an intravenous NO donor compound, but they didn't see any outcome, and the primary outcome was infarct size, risk area, troponin release. There was just the same as a placebo-treated patient. So again, no benefit there. We took a different approach and trying to come up with another way to target the cascade of events that lead to reperfusion injury, and this is by inhaling nitric oxide. And here I summarize like 10 years of work in our lab, our colleagues and friends in Boston and in many laboratories, where if you inhale nitric oxide, what we observed is that, as you all know, it's a selective pulmonary vasodilator. That why it was developed for pulmonary hypertension. But at the same time, we realized that NO, when you inhale it, has remote effects in vascular beds. And that is because it targets platelets and white cells when they pass through the lungs. They have effect on the activation status of these cells. We clearly demonstrated all of that in separate papers. It also binds to proteins in blood cells and can be released at sites of low oxygen level from these proteins, so there is regeneration of NO at distant sites. It can be oxidized to peroxynitrite or nitrite and then be reduced at sites of low oxygen tension to NO. So what we did after a lot of preclinical work in large, small animals that was, in our opinion, convincingly showing the benefit, we randomized patients with myocardial infarction. It's a 250 patient study, so a phase 2 study. At the time when they came to the cath lab, we randomized them to either control treatment, traditional PCI, with in the experimental group. It was a double-blind randomized study, 80 ppm of NO inhalation for 4 hours based on our large animal work. And then the idea was to, or we did first MRI early on and at 4 months, and then again at 1 year. And the hypothesis was that by inhibiting this cascade of events during reperfusion, we could protect the heart and reduce infarct size. What we observed is if you look at the control and the treated arm in the infarct size over LV mass, there was a neutral effect, whether you look at it as absolute or relative to infarct to risk area. So this was puzzling to us. We had expected, of course, and had hoped for a benefit, but what we saw in a pre-specified sub-analysis is that there was a great interaction and a very significant interaction with the NO donor compound use in patients, because we left it up to the investigators. Those that had not received nitroglycerin, the NO donor, benefited from the treatment, and the patients that did not, those that received the drug, they did worse. Those that did not receive nitroglycerin had a significant benefit. So, and that translated also in a better remodeling. But overall, of course, the trial was neutral. So why is that? The hypothesis was that inhaling nitric oxide would keep cyclic GMP levels sufficiently elevated. If you would give a nitroglycerin NO donor, which has an oxidative state of +5, NO2 has +2, it needs a 3-electron reduction before you can generate nitric oxide. And this is the problem. We never observed this increased cyclic GMP level just by administering nitroglycerin. There is in reperfusion injury excess ROS. It complexes with this drug to form peroxynitrite and hence increases injury. So if this were to be right, cyclic GMP increases should reduce by its effect on circulating white cells. White cell activation and myeloperoxidase is one of the better markers, and this should not be the case if you combine it or if you solely give nitroglycerin. And what we observed in our trial is that yes, as long as we gave nitric oxide by inhalation, cyclic GMP levels remained elevated, not in the patients that were randomized to control. And if you look at the myeloperoxidase levels in the circulation, there was only a significant reduction in those patients that received inhaled nitric oxide. To then prove that the interaction was biologically relevant, we went back to our porcine model and randomized pigs to either the combination therapy, inhaled NO by itself, or nitroglycerin. And marked observation was that with nitroglycerin, this is all MRI, the infarct size was larger than in the inhaled NO arm. So there's something bad about giving nitroglycerin during reperfusion injury. We worked it all out. It turns out we think that it increases permeability, increases hemorrhage in the heart at the time of reperfusion. And guidelines for myocardial infarction treatment only indicate the use of nitroglycerin intracoronary is left to the discretion of the operator. So we think it's not a good thing to give a high dose of nitroglycerin intracoronary at the time of reperfusion. Finally, and this is my last few slides, we also looked at novel ways of supplementing NO in ischemic hearts. And this is a set of work that we started several years ago. And we looked at endothelial progenitor cells that are really modulating vessel growth, not only angiogenesis, but also arteriogenesis. And these cells are being isolated from blood samples. These are the markers that confirm their endothelial phenotype. They take up acetylated LDL, are CD31 positive, and form nice tubes in vitro in 3D and 2D models. What I'd like to show you here is that if we expand these cells, this is an autologous expansion protocol that took us some time to really develop in the large animal model, but what we observed is that it increases the vascular development in the border zone after myocardial infarction. You can see here the stainings, and what's really nice to see if you genetically label these cells with a nuclear marker, you can see here these blue cells really integrate in the border zone in neovessels. So these cells can contribute to additional neovascularization by integration. The question is, can heart failure patients, can we isolate these same cells from blood samples from heart failure patients? The answer is, after many years of trial and error, yes, we can do it now with greater than 90% efficiency. The same cellular phenotype from heart failure as from control patients. They have equal amplification characteristics, and we can grow from one 60 ml blood sample more than 100 million of these endothelial progenitor cells. When we use those human cells in a mouse model of hind limb ischemia, we observed increased small arterial development with micro-CT analysis. And again, we showed that these human cells with a human CD31 label integrate in the murine vasculature in the ischemic hind limb. Finally, and similar to what Philippe told you on Thursday, the question is, can we sustain autologous expansion of cells for future clinical applications, or should we look at paracrine effects, whether they're equally beneficial? So in all these patients, we generated the cells, and we also looked at, from these BOEC, the exosome fraction, and wondered, would the exosomes carry all the markers and molecules that would be beneficial to mediate the biological effect? With the transcriptome analysis, you can see NOS3 is highly expressed, The microRNAs that we discussed earlier this meeting involved in vascularization are expressed in these. And you can show, or we showed that equally effectively the cells or the exosomes from the cells can drive tube formation and sprouting. And then we did an in vivo model, and that's where we are now in the nude mouse, a wound healing experiment where we compared administration of cells versus exosomes. And what we observed is here that the exosomes in red even outperformed the closure of the wound because you can really topically administer them. So in conclusion, I think impaired signaling is critical in pathophysiology of heart failure. I think the oxidative stress is very important and limits traditional interventions based on pharmacological molecules. I think for the inhaled NO, we need additional studies, and that was also something that was highlighted in the editorial accompanying our study. And then for cell and exosome-based studies, I think it looks interesting and promising, but also again there, we need additional studies. And this is just the people that help with the work. Thank you.